Hi, my name is Jason Bartlett. I'm an ACP2 with the Queensland Ambulance Service based in metropolitan North Brisbane. Today I'll be doing an exemplar video presentation for PAR 5440 on surgical cricothyroidotomy. Within the QAS, only our high acuity response unit team are indicated to RSI. The surgical airway is the definitive endpoint. It's the common endpoint for any failed airway algorithm during an RSI process, and therefore any practitioners or clinicians that are going to be doing RSI need to have a well-practiced, well-established failed airway algorithm via surgical cricothyroidotomy. The QASs have an indication for can't intubate, can't ventilate situations or severe facial trauma that contraindicate an initial laryngoscopy. Contraindicated for under the age of 12, and due to the requirements for this presentation to talk about different age groups, I'll also briefly talk about a needle cricothyroidotomy that will allow some emergency transtracheal ventilation to enable oxygenation until that patient can get to someone that can do a definitive surgical airway. Unfortunately, I don't have an airway mannequin that I can do a surgical cricothyroidotomy on. So I've had to make up my own using some ventilation hose and a bit of an airway, which I'll use to actually demonstrate the procedure of a surgical scalpel finger bougie cricothyroidotomy.
The anatomical landmark we're looking for when performing a surgical cricothyroidotomy is the cricothyroid membrane, which is located inferiorly to the thyroid cartilage and superior to the cricoid cartilage. In females, it's more difficult to find than males due to the prominent anatomy of the thyroid cartilage, and obesity and tissue overlying these structures may make it difficult to find. Some considerations to be given when performing a surgical cricothyroidotomy: the patient must be very well oxygenated prior to the procedure, and there is significant potential for hemorrhage, so suction and extra hands with padding to absorb any hemorrhage should be on hand.
So obviously wearing PPE, given that one thing I've taken away from some of the FoamEd podcasts is that you will get blood, no matter whether you're left or right vein, just because of the amount of vascularity, you will have blood in the actual procedure. So demonstrating the landmarks and how to find the cricothyroid membrane, if we use what Rich Leverton refers to as his laryngeal handshake, you find the hyoid bone, and then maintaining a wide grip, you come down over the thyroid cartilage till you've located the thyroid cartilage, continue lower till you find the cricoid cartilage, and then with your dominant hand you find the cricothyroid membrane. Once you've located the cricothyroid membrane, you can swap to our non-dominant hand, maintaining position of the cricothyroid membrane, and get ready for our procedure. So continuing the fashion of my homemade airway, I'm going to use this to simulate some skin over my airway so I can demonstrate the procedure of the cricothyroidotomy. Using aseptic technique, we'd swab the area once again, demonstrating the laryngeal handshake, finding the hyoid bone, the thyroid cartilage, the cricoid cartilage, and the cricothyroid membrane, and locating with my non-dominant hand, using my surgical scalpel and be aware that there will be blood because of the vascularity. So I've located my cricothyroid membrane. With the scalpel, I'll penetrate into the cricothyroid membrane, turn the scalpel and cut the other way, and then twist the scalpel sideways. One trick I did pick up from some of the FoamEd resources is this cartilaginous cage. So once you can remove the scalpel, put your finger into the actual cricothyroid membrane and you can feel the cartilaginous cage, which will be confirmation that you're actually in the right anatomy. So once we've got our finger into the cricothyroid, we introduce the bougie into the trachea. One benefit of using a bougie is that you can actually feel the clicking of the cartilaginous rings using the bougie. So once we've got the bougie, we then take our size 6 endotracheal tube and railroad the endotracheal tube over the bougie, pre-lubricated, and into our trachea until we reach the 2 markers for our cricothyroid. We would then remove the bougie safely, watching for body contamination, and then with our 10 ml syringe, inflate 10 ml of air into our ET tube, and then with our bag valve mask already connected to high flow oxygen and capnography, we would confirm ventilation by the presence of a positive capnogram over 6 different ventilations with adequate tidal volume. And once we've actually confirmed positive placement and we get positive capnogram, securing our tube, we can then use our Thomas tube holder to actually locate the cricothyroid tube in situ. And there we have the procedure of a surgical cricothyroidotomy. Whilst it's not indicated within the QAS, there are services within Australia and overseas that are indicated to do a needle cricothyroidotomy, sometimes in paediatric patients where a surgical cricothyroidotomy is contraindicated. There are commercially available kits for a needle cricothyroidotomy. However, a little bit of more foam ed podcast, I found that you're able to do it using a 14 gauge cannula. You have to have a 10 ml syringe to confirm positive placement of your cannula inside the trachea by positive aspiration of air, and a modified oxygen hose and a suction catheter to provide jet ventilation through the 14 gauge cannula and provide emergent oxygenation until a definitive surgical airway can be performed. So the procedure would be as follows: swab the area to maintain aseptic technique. Use our landmarks again, finding the cricoid bone, the thyroid the hyoid bone, the thyroid cartilage and the cricoid cartilage, locating your cricothyroid membrane. With the 14 gauge cannula, we would puncture into the cricothyroid membrane until we felt loss of resistance. We would aspirate, retract the cannula into a sharps container. Hopefully you'd feel a release of air. Aspirate air to confirm positive placement in the trachea. And then with our oxygen hose attached to 15 litres of high flow oxygen, we can then provide some oxygenation at 15 litres high flow with some jet ventilation into the trachea.